Welcome to the Explainer. Today, we're jumping right into a high-stakes medical detective story. This isn't fiction, though. The culprit is microscopic, the victim could be any one of us, and the threat is growing every single day. We're cracking the case of antibiotic resistance.
So, here's our game plan. We're going to follow the trail from a single patient whose treatment is failing, all the way to the lab where we hunt down the culprit. Then, we'll see how clinicians choose the right weapon, zoom out to see the silent pandemic unfolding globally, look at the counterattack, and wrap it all up with a quick quiz to see what you've learned.
All right, let's set the scene. Our story kicks off at the bedside of a critically ill patient, where the so-called wonder drugs of modern medicine are suddenly, well, they're firing blanks.
Imagine this. A patient has sepsis, which is a life-threatening infection spreading through their body. The doctors do exactly what they're supposed to do. They administer a powerful, trusted antibiotic. But nothing happens. The fever rages on. So why? The answer to that question is something that threatens to push modern medicine right back into a much darker era.
What we're seeing is evolution on hyperspeed. See, bacteria are absolute masters of survival. When you hit them with a drug, some of them find ways to fight back. They might reinforce their cell walls, or develop tiny pumps to spit the drug out, or even create enzymes to just chop it up. When that happens, a once treatable bacterium turns into a formidable superbug.
For decades, we've had this pretty reliable playbook. It's called empirical therapy. Doctors make an educated guess based on where the infection most likely started, lungs, urinary tract, wherever, and they prescribe a broad antibiotic that usually works. You can see some of the common choices right here. For years, this approach has worked beautifully, hitting the most likely culprits hard and fast. But the game has totally changed. For the patient in our story, this standard approach just isn't working. Their infection is caused by a bug that has basically learned to shrug off our first-line defenses. The clock is ticking, which means the real detective work has to start. And it has to start now.
So we follow the evidence down the hall to the clinical microbiology lab. To beat this bug, you first have to know exactly what it is, and more importantly, what its weaknesses are. This is where the investigation really heats up.
It's a really meticulous process. First, you take a sample, in this case blood, and you culture it on a special dish to encourage any bacteria to grow. You know, why do microbiologists tell actors to break a leg? Because they're already busy with their casts. Anyway, once you have colonies, you use some pretty cool tech to get a positive ID on the species. Then comes the most important part, the interrogation.
And this right here, this is the smoking gun. It's the antimicrobial susceptibility report. It shows us exactly how our bacterial culprit responds to a lineup of different antibiotics. And the results are stark. You see all those R's? That means resistant. But then, look at the bottom line. S for susceptible next to meropenem, which is a powerful last resort drug. We found its kryptonite. We have our weapon. Okay, armed with this crucial intel from the lab, it's time to head back to the clinic. But it's not quite as simple as just pointing to the S on the report and saying, let's use that one. Choosing the right weapon here is a really high-stakes decision. This really illustrates the escalation we're talking about. For standard sepsis, you might use one reliable drug. But for a resistant infection like this one, you might need a single, heavy-hitting last resort drug, or even a complex cocktail of specialized agents. We've gone from using a Swiss Army knife to calling in the heavy artillery. And in this particular case, there's another twist. And here it is, the classic wrench in the gears. The patient's chart says they have a penicillin allergy. Now our best hope, meropenem, belongs to the same broad family of drugs. So the big question is our most effective weapon now completely off the table? Well, not so fast. It turns out, and this is so important, that over 90% of people who think they're allergic to penicillin actually aren't. Plus, the risk of a true cross-reaction with our target drug is incredibly low, less than 1%. So, by taking a really careful history of what actually happened, clinicians can often delabel that allergy and safely use the best possible drug for the job. So our patient's case is hopefully on its way to being solved. But their story is not unique. Not at all.
It's really just one single data point in a much larger and frankly alarming global picture. So let's zoom out.
This is hard data. In just the last year, 21%, more than 1 in 5, human cases of salmonella were resistant to ciprofloxacin, one of the main antibiotics we use to treat it. That means for 1 out of every 5 people who get this common food poisoning, the standard go-to treatment is already useless. And this problem isn't just brewing in hospitals. It's on our dinner plates. Why did the antibiotic break up with the bacteria? It said, "I need my space. You're becoming too resistant to my charms." Jokes aside, this is serious. This chart shows staggering rates of resistance in E. coli found on chicken you buy at the supermarket. It's a direct line connecting antibiotic use on farms to the superbugs that make us sick.
And all this surveillance data, it comes full circle, right back to the clinic. This quote from a national sepsis guideline basically says that once local resistance to a particular drug climbs over 10%, doctors are advised not to use it as a first-line best guess anymore. The resistance map is literally redrawing the doctor's playbook in real time.
Okay, the picture looks pretty grim, I get it. But this is not a eulogy for antibiotics. It's a call to arms. The global counterattack is already underway, and it's centered on this vital principle called antibiotic stewardship. Stewardship, in a nutshell, just means using our antibiotics intelligently to protect them for the future. You could say it's about making sure our drugs don't get taken for granted. They're not looking for a long-term commitment. It's about the right drug for the right patient at the right dose and for the right duration. And a huge part of that is de-escalating, switching from a broad cannon to a narrow rifle once you know exactly what you're targeting. And that right duration can vary wildly. Look at this. Treating a kidney infection might just take 7 days. But an infection on a prosthetic heart valve, that is a 6-week marathon. One size does not fit all, and good stewardship prevents both under and over treating, because both of those extremes are what drive resistance. All right, you've been following the clues, you've seen the evidence, now let's see what you've deduced. It's time for a quick pop quiz. Okay, let's go back to that allergy dilemma. What is the right call here? If you said B, you are absolutely correct. Taking a careful history is the key to safely using our best antibiotics and avoiding weaker alternatives that just fuel more resistance.
All right, last one, and this is for everyone. Why shouldn't you take those leftover antibiotics when you get a cold? The answer, of course, is B. Colds are caused by viruses. Antibiotics do absolutely nothing against them. All you're doing is taking a risk with no benefit, and worse, you're helping to train bacteria to become tougher for the next fight.
And this really brings us to the final and most important question. We are in an arms race against 3.5 billion years of evolution. Our enemy has had a huge head start. Winning this fight isn't going to be about one single magic bullet. It requires a massive, collective effort. From scientists in the lab, doctors in the hospital, farmers in the field, and every single one of us in our own homes to ensure these miracle drugs are still around to perform miracles when we or our children truly need them.